So the next topic is about bereavement and grief. Bereavement is a long-term process of adjustment to the death of a loved one and is more all-encompassing than grief. So it can include the expression of pain, sorrow, and loneliness, as well as the possibility of self-insight, redefinition, and psychosocial growth. On the other hand, bereavement process can be viewed as a form of coping, as the person confronts the loss and its secondary stressors. So in Rubens Hill's 1958 ABCX model of coping with stress, adaptation or X is determined by the interaction among three factors. First, which is A, the initial stressor, B, the resources and social support a person must deal with the stressor, and C, the perception or meaning the person makes of the situation. So let us proceed to grief. So grief refers to the cognitive and emotional reactions that follow the death of a loved one. So grief reactions can vary in duration and intensity and can fade and reappear at unexpected moments. So in the study of family members who were responsible for caring for a person suffering from later life dementia, five aspects of grief were identified. First is preoccupation with thoughts of the deceased person. While it is common to preoccupy thoughts on the deceased during grief, this can include memories or unanswered questions. Number two is longing for the person. Longing for this person who has passed away is normal aspect of grief. For this, allow yourself a time to grieve and consider talking to your friends or family. Number three is painful emotions. So painful emotions such as sadness, anger, and despair is part of grieving process. So feel and acknowledge these emotions, but it is also good to consider seeking support or engaging in activities that can bring you comfort. Number four is feeling of disassociation or feeling disconnected from reality. So this can be your coping mechanism during grief. But if these feelings interfere with your daily life, consider reaching out to mental health professionals for for the support. So number five, the last one is sensory illusions that led to the impression that the deceased person was still present. So this can involve sensing their presence or hearing their voice or even seeing them fleeting. If these experiences cause distress, talking to a counselor or therapist can also provide support and understanding. So sometimes intense grief reactions are very similar to some symptoms of mental illness. This is according to Spice of Michigan 2007. So the following symptoms are not usual. They are time distortion, obsessive rumination, suicidal thoughts, mystical experiences, identification symptoms, and confusion. So in time distortion, so time seems to be in frozen. So the person is unsure what day it is. Time moves unusually slowly or speeds by. In obsessive rumination, this telling a story or incident over and over, thinking about the situation involving the dead person over and over. So yeah, number three, suicidal thoughts. So thoughts that the person can't go on living without the deceased person in their lives. In number four, mystical experiences. So these experiences of seeing or hearing the person who died, sensing them with you. So in number five, identification symptoms. So experiences of symptoms that are like those of the person who died, increased use of drugs and alcohol, used to buffer experiences of pain from the loss. And number six is confusion. It is the difficulty concentrating or making decisions. Let us proceed to bereavement and grief among older widows and widowers. So among people who have lost a spouse, intense depression is more likely to be experienced by those who describe their marriage as positive and vital. So it is clear that this loss strikes at the core of an older adult's sense of attachment, social integration, and personal worth. So there are five patterns of bereavement among widows and widowers. First is common grief pattern, which these people had low levels of depression before the spouse died. They experienced an increase in depression 6 months after the loss. After 18 months, they returned to the same low level of depression that characterized them before the loss. Number two is resilient pattern, or people in this group had low levels of depression before the death of their spouse and continued to have low levels after the death of the spouse. In number three, chronic grief pattern. So these people had low levels of depression before the loss, but showed increased grief responses at both 6 months and 18 months after the loss. And number four, chronic depression pattern. These people had high levels of depression before the loss, and depression continued at high levels at both 6 and 18 months. And depressed improved pattern, well, these people had elevated levels of depression before the loss, but lower depression scores at 6 and 18 months after the loss. Factors that affect the distress survivors. So ambiguous loss is another especially difficult challenge for loved ones. So there are two types of ambiguous loss. First, in the first instance, the person is missing and may be dead, as in soldiers who are missing in action or people who may have died in a disaster, but there are no physical remains. In the second instance, the person is physically present but unable to participate in any meaningful way in family interactions, such as when a person is in a coma or in the late stages of Alzheimer's disease. The bereavement process is influenced by society's interpretation of who is the legitimate mourners are and who has experienced a legitimate death. So unacknowledged mourners may be confused about their status and feel guilty or embarrassed by their attachment to the dead person. It is when the relationship with the deceased is not socially recognized or validated. This may include some LGBTQ couples or someone's grieving over their deceased pet, as it is not always widely understood. So in stigmatized deaths are those in which people attribute to the death to an immoral, illegal, or evil cause. These often associated with social disapproval or negative perceptions to the deceased. Examples include deaths related to suicide, drug overdose, or certain illness like HIV and AIDS. So the psychosocial growth through bereavement. So the adaptive process of bereavement involves an oscillation between loss-oriented coping and restoration-oriented coping. So in loss-oriented coping, it refers to confronting one's pain, sadness, and the loss of a loved one and finding a place for the deceased loved one in one's thoughts and memories in order to achieve emotional health and cognitive functioning. So this may include expressing emotions, seeking support from others, and reflecting on the meaning of the loss. However, in restoration-oriented coping, it refers to finding ways to master the practical challenges of the loss in order to make meaning of the death and move along in one's life. So this type of coping involves making adjustments to daily routines, addressing practical challenges, and rebuilding some aspects of life. For example, is taking responsibilities previously managed by the deceased,